Just going to give a kind of a brief overview tonight. Some of you may be familiar with the model already, but just run through some basic indicators, and yeah, feel free to reach out with any questions that you might have. Um, we are recording for people who can't make it to the live session. We'll provide a recording. So if you don't want your image or name to appear, please just keep your camera off, and you could also remove your name if you feel so inclined. So, being an old counselling psychologist, common factors has been a really important part of my background. The idea that we are uh, working with things that are not just treatment specific, that are just not just model specific. I think we all kind of share a view that there's something more that's happening in psychotherapy and psychology than just pure clinical models. So that's what we're trying to kind of explore when we talk about common factors, and the three pillars approach to it is what we've come up with as a kind of a very straightforward way of framing this work up. And this work, the three pillars, comes from the work of Daniel P. Brown, who I worked very closely with for quite a number of years, and also David Elliott. So therapy works, but we can't still agree why and how. So, we're now up to about 500 plus named therapeutic models. And one of the confusing things for us all is that, these 500 plus different therapeutic models, have theories, have rationales, have research base that demonstrate efficacy, yet they don't often agree in what it is that they're doing, what they're saying. A CBT view of human functioning is very different to a psychoanalytic view of human functioning. Um, but the kind of orientation that we would take is that they're not. It's not that they're all wrong. Um, we'll get to that in a little while. The outcomes seem to indicate that treatments work, and yet, other than in some specific, there are cases where specific techniques work for specific presentations. That's true, and there's more research evidence growing along those lines. But in the broader picture, head-to-head trials produce remarkably similar results across the board, and that was famously named, the dodo bird verdict. All shall have prizes. Um, the idea that something's working all along, that each of these different modalities have some clear efficacy. Common factors research tells us what works, but it doesn't tell us so much how it works. I mean, a lot of the kind of the thinking about common factors work is made famous in Lambert's work, and we understand that is not a strong structured research paper. It's really an overview paper, but it does give us a kind of fairly strong indicator of what seems to be the active ingredients in therapies. So client and extra therapeutic factors come up at about 40%. The therapeutic relationship comes up at about 30%. And what we're talking about here is change. Expectancy and hope, 15%. And the model and technique, about 15%. So, models and techniques are important. So we're not suggesting that they're not. But they're less important than other factors. So client and extra therapeutic factors are things like client resources, motivation, social support, life circumstances. These are all contributors to outcome, which we tend not to factor into our our case conceptualization, our formulation and treatment planning. This is the world that our clients come from and return to. Um, and these have significant factors, significant influence. We see this quite a lot actually in our psychedelic trials, because when people go into a non-ordinary state, they're extremely vulnerable and extremely open, and it becomes just then very important what's happening, what's going on in the world that they're returning to. Had situations where people have been picked up by people who are in relational conflict with, and it just doesn't bode well. So these are really kind of important aspects of thinking about our planning and formulation. The relationship itself, we talk a lot about what the therapeutic relationship is and its importance. It's important to um, bonding, and the bond is something that resembles the attachment bond of a child to a parent in some ways, the therapist to the client. The bond is there to create a sense of predictability in another adult, that there is someone there that will hold space, will reflect, and will not replicate the patterns of development. Goal agreement is a really important aspect of that relationship building, so that there's a collaborative sense. We're working together. This is a way to amplify and increase trust, that we're working on the same task together, that we agree that what we're doing here, that I'm not a therapeutic expert that's going to do to you. Rather, we're two people working together. I've got a set of skills that I can offer, but they need to work for you, and we need to agree. This is the collaborative kind of goal we'll talk about again a bit later. Most research variable in psychotherapy, the therapeutic relationship, with more than 1,000 studies, and it predicts outcome and dropout across modalities. So a CBT therapist who is good at establishing a therapeutic relationship has better outcomes than a CBT therapist who doesn't. Similarly, a psychoanalytic therapist who can build relationship has better outcomes than one who can't. The way in which, and I think there's something in the current kind of trends to really build more kind of a pathologizing um, approach to psychotherapy, psychology, to look more to specific diagnosis, the presenting problem as the primary goal. I think we can often miss this expectancy and hope part. This idea that there is something that will lead to more benefit. There are strengths that are undiscovered or undeveloped that are available. It's a really important part, I think, of good therapy is being able to help the person see that they have ability, that they have capacity, and that therapy can improve, not just mitigate suffering. And then models and technique become important considerations. So being able to, systematically work through a program to be able to target in an agreed way is a really important feature. An important feature of all therapy. So the mechanisms that we bring into question, what we know what works, and we still need to have an understanding of how it all works. And there are a number of different ways that have been explored, and that are an increasing number of ways that are being explored. Walpole's contextual model describes pathways, relationship, expectancy, technique, but doesn't really talk about what the underlying psychological mechanism of change is all about. Self-determination theory explains why the conditions matter at the level of basic needs, but not what changes within the person as a result. Process-based therapy now being developed by Stephen Hayes and colleagues specifies modifiable processes with clinical precision, but is less concerned with what is universal across therapies. So they're really focused on their own practice to good effect. The dodo bird verdict remains real and robust. However, we do know for presentations like OCD, PTSD, specific phobias, technique does increasingly clearly carry more weight than simply the relationship and rationale alone. In recent times, there's been a real growth in interest in this approach to psychotherapy. So significant research coming out of Harvard now that really looks at a common factors approach. So looking at what's working in different modalities, their interests. So Gunderson and Troy Kane. Troy Kane was out here recently, towards the end of last year, where they're looking at what common factors treatment for borderline personality disorder can be distilled from dialectic behavior therapy, metacognitive behavior therapy, transference focused therapy, and schema focused therapy. These different models that all show effect with people with borderline personality disorder diagnosis. But why have these discrete models? What they're looking for is what links them, what are common to each other. And the general message was that it was that the general common factors approach was not inferior to dialectic behavior therapy, despite being far less resource intensive. It outperformed DBT for highly comorbid and impulsive presentations. So there's something there in common factors that's working. And there's been an interest locally with Spectrum, our local organisation that specialises in borderline personality disorder presentation. They've developed a treatment approach using common factors. And the principles are that not one treatment model is superior. Divergent approaches share common features that are equally effective in addressing the central features of, in this specific instance, borderline personality disorder. So I'm just raising BPD as an example where common factors work is really being seen to be quite effective, and it's a beginning process of starting to look to the core features of different therapies and finding what works. So what we'd suggest is that an answer to the mechanism question comes in the way of thinking about mentalizing and metacognition as a movement of information. So rather than state specific, rather than looking at a diagnostic presentation, this person is depression or anxiety or borderline personality disorder. What the mentalizing and metacognitive models are starting to do is direct our attention to the way in which the mind processes information rather than what the diagnosis is. Diagnosis is fine, and that could be important, but what's leading up to the diagnosis? What's happening around features of organisation of mind, and how are these enacting? And what all effective therapies share, which is beneath their different techniques, is that they cultivate the client's capacity to follow the movement of their own experience in some way or another. So if we're talking about CBT, what we're talking about is being able to follow the way that negative automatic thoughts influence response and behavior, and that shifting from a negative automatic thought to an alternative assessment by teaching them to track thought, that creates positive change. If we're looking at a model like emotionally focused therapy, what we're inviting people to do is learn to track different affects, different emotions as they run. What's a primary and what's a secondary emotion? Principles here are that the mind is information moving. And we move from the bottom up, from sensation, where we all start as little infants that have very little capacity to do much other than experience the world completely rawly. Then feeling comes online for children, just as senses come online for babies. Affect comes online. It comes online through the relationship with the adults around them. And that then leads developmentally through into kind of imagery, the capacity for a child to create internal presentations of adults and how they anticipate and accept adults. This is what we talk about in object relations theory, for instance. And then eventually this kind of symbolic meaning moves into something a little bit more abstract, reflective thought. And so the mind is this constant process of information moving from simplicity into increased complexity and increased abstraction when we get to sort of cognitive thought. Mentalizing then becomes a process that begins it's sort of it starts with the attachment bond. That's the kind of the first principle of mentalizing, that a child learns to predict relationship in the world by the way that adults respond to that child. And so the child's affective systems develop, grow, modulate as they're being responded to by an adult. So mentalizing begins at this very, very visceral level, but then begins to develop with increasing levels of sophistication as the child grows into an adult. And of course, it's that failure to really develop robust mentalization that Bateman and Fonagy point to as the core problem in the work they do in borderline and antisocial personality disorder, where they're looking at the collapse of the capacity to mentalize as the core problem, that the individual is not able to stably experience their own mind and the mind of another. So the flow of information isn't clearly reciprocally operating. That the person who doesn't have mentalizing capacity can't see mind of self and mind of other. What they can see, for instance, is mind of other as threat without mind of self being present to it, or their own mind dissipates as they try to embed themselves in the mind of the other. The third phase of this kind of mechanism question is metacognition. Metacognition and mentalizing are overlapping principles. It wouldn't be correct to say that they are separate or different entirely. Because when robust mentalizing occurs, this is what leads to what Fonagy describes as reflective function. Fonagy developed reflective functioning theory and the reflective functioning scale following his work with Mary Main, where Mary Main developed the adult attachment inventory, which is a really robust way of understanding the organisation of mind of an adult in relation to their attachment dynamics. And Mary Main introduced this idea of metacognitive view. She could see metacognitive monitoring the mind that can reflect upon itself. And Fonagy kind of really ran with that and developed it into a reflective functioning scale. And this is a capacity during mentalizing process to see mind of self, see mind of other, regulate your own mind in that process. Metacognition starts to become a more broad view, and it starts to see more clearly the patterns. So it sees beyond reflective function and starts to see deeper and broader patterns, interactive patterns across time, relational patterns that have been handed down generationally. So it's a very broad-based view. Mentalization, as described by Daniel P. Brown, is a function of the medial prefrontal cortex. So it's an autobiographical processing about interpersonal interaction. Metacognition is what he would describe as a right dorsolateral function. And so it's an observation of the autobiographical processing. So whilst the autobiographical processing that we all possess can be self-aware, there's increasing levels of perspective that we can take on that. Different schools offer the same operation in many ways. So CBT has a restructuring process where we're looking at creating some kind of separation of cognition, some separation of thought. ACT looks at diffusion, separating thought from emotion, recognizing how these two processes can influence each other in a negative way when there's no clarity on separation of these as processes. Psychodynamic processes move to generating insight. So the idea there is that by understanding early developmental patterns, early developmental needs and interactions, that you'll free yourself of those compulsive patterns. Mindfulness looks at decentering. So it looks at being able to teach someone to simply observe whatever process is available, whatever process is occurring, to take an observational perspective on it and to not be drawn into identification with whatever's arising. And that's a difficult kind of task. You know, anyone that's been on a Vipassana retreat will know how uncomfortable that process of just sitting with information as it arises can be. But each of these processes are really teaching the client to track and follow a particular movement of their own mind, whether it's thought-based, whether it's developmental pattern-based, whether it's emotion-based. But what we're doing is we're teaching people to track and observe features of their own mind. So what we've been working on over the last few years, I think I met Dan Brown in about 2013, and his major book on this model was published in 2016, The Three Pillars. And it's not another kind of model of therapy per se, whilst, you know, within the attachment work that Dan developed, there is a particular technique or a particular set of problems. But more importantly, what he sets up are more meta conditions for good therapy. And so the three pillars becomes a clinical organizer, not a new therapy per se. Each pillar maps onto the part of the common factors evidence and gives it a clinical architecture. So pillar one is collaboration, the relational condition. And collaboration in Liotti's work, collaboration has been presented as a motivational system that is superordinate, that it's the system that human beings are naturally drawn to under major points of stress. So if there's a bushfire, humans gather together to help fight the fire. If there's a flood, humans gather together to support each other. When there's a war, we gather together and we support. There are, of course, outliers that don't engage in that way, but it's this collaborative system that is extraordinarily powerful in humans. E.O. Wilson, the etymologist, observed the way that people were working in the laboratory, and then decided that he'd develop a whole new area of study called sociobiology, where he's really exploring the way that humans work together to achieve things. Think about your morning cup of coffee. Just what an extraordinary chain of events occur to get that coffee into your cup. There are coffee beans that are grown somewhere in the world that are harvested, that are then transported, and they're then brought into warehouses, and then they're roasted, and then they're brought into the cafe. It's an incredible chain of interpersonal connections. It's an extraordinary feature of our species, and it then becomes a really core feature of good therapy. Being able to establish the collaborative frame creates a quality of trust and predictability in the therapy that allows for the exploration of other motivational systems. So, under threat and fear, the collaborative system can collapse. When the collaborative system is engaged, then people can explore, for instance, the attachment system and whatever wounding is occurring there. Collaboration keeps this kind of open, and it's overt collaboration we're talking about here. It's our having a clear therapeutic agreement in um, in the room with a client about what can be said, how things should be said, how we conduct ourselves, so that the client is able to predict that the therapist is going to meet them in ways that don't replicate wounding and pain, that there's a clear agreement in how the relationship will be conducted. And it's this establishment of collaboration that creates the safe container for the work to occur. And that, is what the common factors work is showing us, the need for the right setting, the right conditions, the right attitude. And then the second pillar that Dan pointed to was metacognition. And this is really the formulation lens. What we're looking at here with metacognition is really understanding the flow of information that's occurring in a client's mind. And what we've done is set up a structure by which we can track metacognition across four registers. And what we mean by the four registers are simply broad clusters of phenomena that develop um, sequentially across time, but which aren't like a step ladder of discrete, I've finished this one, I'll move to the next one, but rather that they're recurring, looping feedback systems. So what do I mean by that? At the basis of our early life is sensation. And all a baby can do is absorb sensations, sight, sound, smells, touches. They can't do anything with them. They can't organize them in any way. They can't make sense of them. And as the complexity of the brain develops, the baby then starts to develop affective systems. They're stimulated through the relationship with the parent. Affect comes online after a few months and starts to develop more robustly. The next register that a baby moves into is the movement from being a little grouping animal into being a little human. And that's a symbolic register. This is where in our early ancestral past, our ancestors, moved from being just another type of monkey to a very specific species that started drumming, painting on cables, dancing, chanting, creating these interpersonal relationships that were based on some symbolic representation of an event in the tribal life, and something that really bonded people together. And so we go through as like a little fractal. Each of us sort of replicates our evolutionary history in the way that each of us grows from sensate into affective into symbolic. And you see this in little kids, like really young children. You give them a stick and a stone, and all of a sudden they're creating a universe. The imagination is so rich. It organizes emotion beneath it, but it's also not often or not always linked to logic and reason. And that's the next stage of development, cognitive stage. So we grow from the bottom up. And eventually, what ends up happening in the way our culture is set up is we start to then become oriented from the top down. So, our culture, it's like a whole bunch of heads on sticks. How many of our clients just can't connect with their bodies, can't connect and can't name their emotions properly because all of our education orients us to being thinking animals. Our feelings, our sensations, our intuition, our instincts aren't actively supported, aren't encouraged in our culture. So what we're talking about with metacognition is being able to help people process and recognize the movement of information from the bottom up to the top down and to notice the recursive looping that goes on there. The more clarity we have about our emotional states and our emotional responses, the more clarity we have about emotions, the more knowledge we have and the more capacity we have to work our way through the emotions rather than acting them out. We talk about these processes as regulated through the three tiers. Tier one is just raw input coming in. Tier two is mentalizing. Tier three is metacognition. And then the third pillar is what we describe as an operation that's central to all therapeutic modalities. They all do some form of this. And that is that we're tracking phenomena as it's moving. We're marking it. So in the therapeutic room, it's like, oh, what happened then? You see a client do something and you're tracking them and you just mark something that's happened. And then what we try to do is name that with them, and help them name it. Oh, when you said that, I just suddenly remembered what happened to me 5 years ago. And suddenly their minds moved somewhere else. And without any kind of shaming or blaming or anything like that, we just help them recognize, yeah, your mind's moved that way. When, what was that? Oh, I was just remembering something, a really terrible event. So we're naming it. We're marking it, we're naming it, and then we'll shape that. Okay, what would you like? Well, it would be okay just to take a few breaths and just come back to the here and now, and we can go back and look at that again. So therapeutic techniques will have a lot more detail about what to do with the shaping, and they'll have certain things to follow and certain practices and processes. So again, I'm not in any way suggesting this is replacing the work you do in whatever techniques that you're trained in. It's just simply looking more closely and clearly about what's happening within the context of those techniques. So, as I mentioned before, collaboration is a superordinate motivating system in Pillar 1, and it quietens the other systems. Collaboration is a distinct evolutionary motivational system about shared goals between equals. And, it helps us hunt, if one of us is out in the Serengeti with that little pointy stick, we're probably going to be lunch for something pretty quickly. But if, 10 of us are there with our pointy sticks, there's a good chance that we'll be able to bring home barbecue for lunch. So being able to collaborate and group together is an important part of our evolutionary history. Um, It overrides attachment. Attachment destabilizes mentalizing and disorganized clients. It it overrides social rank, which collapses into submission and dominance, which distorts work. If our client sees us as superior, it then creates a whole dynamic that we need to then work through. Defensive systems, threat mode forecloses the channels. So collaboration keeps the client out of collapsing into these type of um, non-mentalizing processes. And under collaboration, the rest of the work can begin. Therapeutic alliance, bond, the goal, task agreement. So collaboration is really responding to a lot of this material from common factors research. It moves towards a condition of epistemic trust, which is core to Bateman-Fonagy's work in their mentalization-based therapy. Epistemic trust is a deep sense of feeling that you're okay in your body. And for the 50% of the population who have secure attachment from infancy, it's a given. It just sits there as a kind of a sense of who I am. I feel secure in myself. I have good self-esteem. Epistemic trust can be built, but for people with attachment disturbances and many other disorders, it's not operational. Collaboration can help to build and establish that. Mentalizing can come online when our clients feel that we're collaborating with them, that we're their support, we're their agent. They then start to be able to mentalize and see themselves and see us. So the mind to mind interactions become clearer for them. And rupture and repair becomes possible where we recognize, we missed that, or we didn't connect on that, or I misunderstood that. When we're in a collaborative frame, the repair of that rupture becomes really core to the work that we're doing. Metacognition, as I mentioned before, is formulated across 4 registers: the sensate, bodily states, as bodily states. This is all the great work that's done with things like sensory motor processing, or you know, um, the Peter Levine work. It's all about noticing and recognizing the sensate as it rises up through the body. Affective processing is the second register. Symbolic is the third register, and then cognitive processing. And these registers are tracked and followed through initial observation of raw input and survival drives. That's the primary kind of source. Then we move into mentalizing, where it's a self and other processing that starts to occur, starts to build. And then, sorry, there's a typo there. Tier 3 is this metacognition. And so, again, pillar 3, just to recap: tracking, following the movement, sustained moment-to-moment monitoring of how experience moves across these registers, tiers, and flows. Marking it, just creating a gap, starting to kind of bring in a positive mentalizing relational frame into the therapy. Naming it, so turning it into something that can be symbolized, something that can be seen, understood, shared, and discussed. And then we shape, and that's whatever therapeutic techniques that you are using is to help to create new structure, reorganizing the architecture, reorganizing how people experience their emotions or remember their pasts, integrate traumatic events. There is contesting of the common factors account, and I think it's always healthy to question anything. No, we're not at the point of understanding ultimate truth. So there's questions around the dodo bird phenomena being overstated. So, there are research outcomes that show CBT advantages for presentations. Treatment specifically emerges in quite a lot of meta-analytic studies. So, there's arguments there for treatment specific approaches, which is true. Um, Correlation, alliance outcome data are observational. There's no real kind of thing that's being measured. Underpowered comparisons. So head-to-head trials lack the statistical power to detect realistic differences between modalities. Risk of circularity, increasing tight definitions of bona fide therapy, risk making the position unfalsifiable. That it devalues specific techniques for ERP exposure and behaviour activation. The procedure doesn't work. It does work. The relationship can't. Limited mechanistic theory. The sequential processes of change implied by alliance research has not yet been confirmed empirically. So the responses from the three pillars framework would be that it specifies mechanism, matches technique to presentation, and makes clinical decision formulation led rather than orientation led. So we're not saying it's a perfect and fine position. Rather, we're just saying that there are these structural processes that really add to the quality of the work we do. And the implications from all this are that there are five implications. The relationship is the work, not preparation for it. Therapy is introduced, is therapeutically active. Client strengths are the largest unmet contributor by far. That they're under resourced there. Who the therapist is matters as much as the model. How you bring yourself in, the way that you establish relationship, and if you track that back to attachment dynamics, the fact that people respond incredibly positively, and it builds into epistemic trust when people feel seen and heard and considered. And we also need to routinely monitor outcomes of anything that we do to ensure that what we're doing is helpful. So just create some space now just for people to ask any questions. We've got a few minutes. And if you want to get in touch with us, there are our contact details. Feel free to reach out and let us know if we have any questions about the work we do or the trainings that we offer. Please reach out and